Got a rowdy crowd here. She went to Harvard and graduated a non-shabby summa cum laude, and then she went to Yale Medical School and then UCSF Dermatology residency. She has done both presentations and research on targeted chemotherapies on PD-L1 and PD-L1 ligand, lichenoid mucocutaneous reactions. And she has presented a number of times in the last few years at San Diego Derm Society on dermoscopy. And last year, she received a teaching award by the Academic Clinicians of Scholars for excellence in teaching. And we're very fortunate to have her here as faculty at UCSD and are very lucky to have her talking with us today. Welcome, Dr. Shi.
Thank you, Dr. Romero. So this morning, I'm going to be talking to you guys about dermoscopy. It's a topic that I really enjoy learning about personally, and then also just using it in clinic. I think it's a really great tool and, really helpful and challenging to master. I don't want this to be a repeat for a lot of the residents who have seen some of this in lectures. And just for everyone, I really want this to kind of be a highlight. I'm not going to go through, the exact rundown of all the individual features of what to look for each lesion. There will be a little bit of that, but this is really meant to be kind of more practically useful. And I hope to just share some helpful pearls to keep in mind when you're in clinic using dermoscopy. So I don't have any commercial or financial interests or disclosures. I do mention some products, but they're just kind of the typical ones and ones that I've purchased myself. So brief outline, we're going to just start with a couple non-melanocytic things, then go into some melanocytic lesions, and then talk about acral sites, including briefly nails, and then kind of a fun way to end just a little bit on trichoscopy. So all of these, again, it could be like a 10-hour lecture, but we'll just kind of hit some of the highlights. Whoops. Whoa. Oh, okay. I don't know why it's doing that. I'm going to use the mouse. Doesn't like the arrow keys. Oh, okay. Sorry. I know, and we're done. No, just kidding. Okay, I think the up and down keys will work. Okay, we're gonna try that again. All right, so just to start off with the super basics, dermoscopy is a really great non-invasive way, obviously, to look at skin lesions. And on the right here are just some of the most common dermatoscopes that people tend to use. So I personally have the DL4 from Dermlight, which is up at the top. The one kind of in the middle is also Dermlight. It's kind of the, I think, more towards the entry level, but it's the 2 or 200 tier. Honestly, that one's pretty good too. It's a little bit more affordable than the DL4. And then I know a lot of people also like this one down on the bottom, which is from Hein. It's a Delta 30. It's a little bit bigger and heavier, but some people like that one. So all of these dermatoscopes have a light source and a source of magnification, and then they should also have polarized and non-polarized settings. And so the difference between those two settings and the key thing to remember is that if you're using non-polarized, you always need contact with the skin. And if you're using contact, you're going to need some sort of fluid. So that can either be ultrasound gel, mineral oil, and then, most people aren't really using that in clinic. So sometimes in a quick pinch, you can use an alcohol swab and really kind of saturate the skin and then immediately place the dermatoscope on. But just remember, you always need contact to use non-polarized. For the polarized setting, you can use it contact or non-contact. So usually that's the setting that I'm using in clinic just because it's a little bit easier to use non-contact. Polarized settings are going to let you see deeper into the skin, and then non-polarized settings highlight the superficial structures. So on the bottom left, you can see that with non-polarized, it's a little bit easier to see the scale. You can see some areas of erosion on the top. So there's a little bit of scale like right here. And then with polarized, you see deeper. So I think that usually the pigment and the colors are a little bit more vibrant, and that makes sense because the pigment is deeper. So you're able to see that a little bit better. Okay. Okay, this is what I just bought of my own initiative. I have enjoyed using it so far. It's what I use during clinic to take photos, and then like all the photos you'll see in this presentation are using this. It just attaches straight to your phone. Doesn't have to be an iPhone. It can be any phone. And it just lines up the camera with your dermatoscope. You can also just do this manually, but sometimes it's hard to like get everything lined up and in focus. And so this ring of magnets just clamps onto the DermLite dermatoscope, and it makes it really quick and easy. Sorry, guys. Okay, so for non-melanocytic lesions, we're gonna start with AKs. These obviously usually are pretty easily diagnosed clinically. You're going to see erythema in the strawberry pattern because the follicular openings look white, and so that breaks up the red erythema. You can have scale. You can also see pigment with AKs. And then one feature that used to be thought of as pretty specific for AKs is rosettes, but we now know that that's not really specific. You can see rosettes anywhere. But it used to be thought of as maybe a clue that you're dealing with more of an AK. The rosettes are seen in the top right photo here. They look like little 4 white leaf clovers with 4, clovers. And they correspond to the follicular openings. Okay, the pearl here is that typically AKs tend to have larger follicular openings compared to other lesions. And what's also interesting is that they look different on non-polarized and polarized settings. So the rosettes you're only going to see with a polarized setting. So you can see that there on the right. And then if you actually look with contact, non-polarized, you won't see the rosettes, but you'll just see these really large white follicular plugs that kind of have this halo, and they're the exact same structure. So sometimes that can be a clue, especially like if you're looking at a facial lesion and it's pigmented and you're not sure if it's a pigmented AK or maybe a lentigo or even a lentigo maligna. Sometimes you can kind of get a sense, but it's still challenging because AKs actually have a little bit larger follicles. The more you start to look at facial skin and lesions and kind of get a sense for the normal follicular size, that will kind of build that pattern in your head. Okay, so with SCCs, usually pretty obvious clinically, you're going to see a lot of hyperkeratosis, a lot of scale, but often the vasculature can be helpful. So the lesion on the bottom left is super obvious clinically. But if you look at the periphery of these lesions in SCCs, you can often see specific vessel patterns. So usually with invasive SCCs, you're going to see hairpin vessels. And these are either just like a single looped vessel, just looks like a bobby pin. Sometimes it can have multiple loops at the end, but the overall shape of it is still a loop. And that's shown down here in this photo, these nice looped vessels, usually again at the periphery of the lesion. If you see glomerular vessels, that is usually a clue that you're dealing with the in situ subtype. So glomerular vessels are just really tightly coiled vessels, and you can see a nice example of that here. I really hope it's not going to do this the whole presentation. I don't know. What if I just try it again? Have you ever had this problem? I don't know why it's doing that. Whoa. I don't know if it's because it's on my USB.
Let me get to that slide. There we go. Let's try.
Yeah.
Let's click on it.
That's okay. We might try to make it. Maybe I can
It's
just.
because they're all checked like that. Okay.
um,
Share.
Maybe unput these timing. Okay.
Sweet. We're good.
Okay.
Oh, and then we just gotta start the share. one
Yeah.
more time.
Right. Sorry, everyone. I think we fixed it. This one, right?
Mhm.
Share. Presenter. Okay. Okay, great. Hi, video coming? No, recording. Great. Okay, that's much better. Sorry. Okay, so going back to glomerular vessels, they can be seen in SCCIS, but I have noticed that there are a couple other lesions that can also show this vasculature pattern. So there's basically three main things if you're seeing glomerular vessels. It can either be an SCCIS, it could just be a very inflamed seborrheic keratosis, or sometimes you can even see this in scar. When I first started looking for these vessels, I was biopsying a lot of scars, thinking that they might be SCCIS. Sometimes that happens on the lower legs commonly. People come in with all sorts of scrapes and things. So you can see that they look really similar. On the left is an SCCIS. Often the glomerular vessels are really small, so they just look like dots, so they can be dotted vessels. And then on the right, I know that it's a little hard to see. I tried to kind of blow up the magnification. So on the top is an SK that was biopsy proven, and then the bottom was also biopsied as a scar. And you can see that honestly, it looks really similar. You're just going to see these pretty regularly spaced glomerular vessels, but these three things are kind of your main differential anytime you see little tightly coiled vessels. Sometimes a clue that helps you with figuring out if it's an SK or an SCCIS is that with SKs, the vessels should be centered within this little white halo, or sometimes you can even see like down here, like all of these are little individual lobules, like little papillations of the SK. And you can appreciate that it's like really evenly spaced, very regularly spaced. Often they're small hairpin or looped vessels, but again, you can see glomerular vessels too. So with BCCs, there are three main things that you want to look for, and BCCs have a really specific dermoscopic pattern. So one is the vasculature. So you're going to see these arborizing vessels, branching telangiectasias. You often see pigment, not always, but pigment is a really, really big clue with BCCs. And you're going to see these globules as well as maple leaf structures like here on the side, and then spoke wheel structures where you have these streaks, or I guess buds of pigment kind of coming out of this darker center. And then often with BCCs, you'll see erosion too. So if you see something that has all three of these features, it's a pretty good diagnostic sign that you're dealing with a BCC, and you can tell the patient that, and you can counsel them appropriately. The pigment, There's all sorts of names out there in the literature. So spoke wheels, concentric structures, leaf-like structures, they're basically all variations of the same exact thing. And so sometimes you don't get these streaks that radiate all the way around. It's just kind of like one half of the pigment. So here is kind of a real life example. This is more of what I would call maybe a concentric structure, almost like a spoke wheel, but sometimes you have these larger globules of light brown pigment and there's no dark center. Basically what these correspond to, it is basically a histologic structure that you're seeing visually, which is kind of cool. So these structures are actually, it's pigment that's in the basaloid aggregates of the BCC. So like, this nest of BCC in the papillary dermis, they kind of come out from the undersurface of the epidermis and they tend to have multiple connections. And so if you actually look with confocal microscopy, you can see, there's this center and then all these little buds kind of radiating out. So that corresponds to the spoke wheel-like structure. What I have found really helpful as a pearl to keep in mind is that in addition to those really classic pigment features in BCC, one really specific feature is these really tiny dots. So I actually really like this figure here on the left. I think it is a very nice summary of what to look for with BCCs. But these really tiny dots, which they call buckshot scatter dots, I find very specific and very helpful in diagnosing BCCs. So you can see that here on the right, there's these really tiny dots. They're usually pretty sharply in focus. And you can see, they're kind of scattered throughout. It's not even throughout the whole lesion. They're usually like pretty haphazardly scattered. And if you see this, you should definitely be thinking basal cell carcinoma. So a couple more examples. You do see, like the nice telangiectasias, they're very fine here as well, branching telangiectasias, but then these tiny pigment dots. So in both of these, you're not really seeing any of those like typical spoke wheel structures or darker globules, but it's really these teeny tiny dots. They can vary in size, but they're usually pretty small. And then this one, there's only maybe like 4, so you don't need a lot, but these are both BCCs. And then another pearl is going back to the vessels and the telangiectasias. They can be subtle, and they're not always going to be really nice branching ones. So the key is actually just to look for really fine, like thin caliber vessels in basal cell carcinomas. And so here you can see that in the center of the lesion, it has these really thin vessels. And the key here is to distinguish them. It's not the same as the broader telangiectasias that you see with chronic sun damage. So that's demonstrated here on the right. Obviously this, you can see it clinically, you don't even need a dermatoscope. But sometimes when you look with the dermatoscope, you see these kind of more diffuse broad telangiectasias. That's really, really common on facial skin that's had a lot of sun damage. And you can kind of see that here, like this is just background sun damage, but hopefully you can appreciate that these vessels have a different caliber. They're super thin. And so sometimes that is the only clue that you see. So I find this really helpful to look for because sometimes clinically you just see this like pink scaly macule and you might just think it's an AK. But if you actually take out your dermatoscope and look, if you see these really tiny vessels, and actinic keratosis shouldn't have any vasculature. So if you see really tiny vessels like this, and over here too in the middle, you're probably dealing with a superficial BCC and not just an AK. And then this picture on the right is a nice example of these more, typical broader telangiectasias. This is all just background sun damage around here. And then again, you can see that these vessels are much finer. So another pearl, this was described maybe a couple of years ago now by Dr. Margoub's group. is something called May globules. And May stands for multiple aggregated yellow-white globules. So they describe this in BCCs that didn't have pigment. And so what they did in their study was they looked at a bunch of non-pigmented lesions. About half of the cases were BCCs, and then they also looked at other non-pigmented lesions. And they found that May globules were usually seen in BCCs as compared to other things like SCCs. I think they had a couple desmoplastic trichoeps in their group. So what they found was that it wasn't in a majority of basal cells. It was only 20% roughly. So it's not a super sensitive feature to look for, but if you see it, it's pretty specific. And so I don't know how well it's showing up. It's kind of subtle in these photos, but you can see, exactly what the name describes, these yellow-white globules in the center here, and then down here as well. You can see this with both polarized and non-polarized settings. And what's also interesting is that they seem to suggest a more aggressive subtype, maybe. So in the same study, they looked at high-risk BCCs, which included more morphiiform and infiltrative types, and found that they were seeing these May globules in about 56% of them. And then they saw also in nodular BCCs, which they called the low-risk BCCs, in about 20% of nodular basals. They didn't see this feature in any superficial BCCs. So their suggestion is that if you're seeing this, it's probably going to be a nodular BCC at least, or a more aggressive subtype. And it represents calcium deposits. And so here again are some more examples of these yellow-white globules highlighted by the yellow arrows. And then a little bit harder to see in this one, but there's a few globules right here. And if you look histologically, it corresponds to same yellow arrows, just calcium deposits in the superficial dermis. So I went back and looked at some of my photos that I had taken, and it is interesting. You do start to see these May globules in some of your BCCs. And so I went back and looked at the subtypes too. So here you can see, a couple May globules here in the middle too, kind of this line. You also see these little tiny pigment dots that I mentioned. And then this one was really striking. It was like very, very bright and very white, and a lot kind of large globules. So nodular, micronodular, and then this one did have a nodular component, although there was also superficial component. So it's just kind of something interesting to think about. If you see these calcifications or the May globules, it's probably going to be a higher risk subtype or more aggressive type of BCC, not superficial. This was just a nice example of kind of everything we've talked about. Clinically, what caught my eye was the pigment at first glance, but otherwise, if you're not looking closely, you might miss something like this. It's skin colored. It wasn't actually super pink. If you look with dermoscopy, you can see all the things we've just talked about, these tiny little pigment dots, really fine vessels. And then you can also see here, there's some May globules. And then there's also more of the typical darker pigment globules too. So kind of a classic example of a BCC. Okay, so moving on, the next pearl I want to talk about is just that gray dots or anything with this annular granular pattern with a gray color is usually a sign of regression. And so that's a very broad blanket statement. So often you'll see this pattern with lichenoid keratoses, but you also want to be thinking about, a melanocytic lesion or a melanoma that's undergoing regression. And so this is a really nice example here of what I mean by this gray annular granular pattern. It's all these gray dots, and this happens to be, the dots are just scattered around follicular openings. So that kind of gives it this annular appearance. So again, usually you see this with a lichenoid keratosis. Now, a clue here is that for whatever reason, if a lesion is involuting or like if it's a seborrheic keratosis that's involuting or undergoing regression, it should start from the outside and go in towards the middle, or it should start from one side and go to the other. And so you can see that here. I'm sorry, this photo is a little blurry with image quality, but you can see that there's this normal kind of lentigo pattern here on the side, and then the regression is starting on the other side. So it's kind of going from one side to the other. Or you might see the gray dots at the periphery. What you should not see is gray dots in the middle. So that is a more worrisome sign. If you're seeing regression or gray dots that start in the center of a lesion, you're gonna probably want to biopsy that or just be more, more worried about that lesion. You can see that here too, where the gray dots are on the side, and then this other side, you can see more kind of lentiginous pigment. It's kind of light, but you can see here, this looks more like a lentigo. So these were just a couple examples that I have seen in clinic. The one on the left has a really nice granular pattern. You see kind of all these gray dots scattered throughout here. And so here, I would say this looks more like a classic lentigo. You have this just like light brown pigment. You have moth-eaten borders down here. I did end up biopsying this just because I wanted to make sure it wasn't a melanocytic lesion, and this was just an LPLK. The one on the right, I thought looked very strange clinically and dermoscopically. So you see this erythema and hypopigmentation and white in the middle, and there's even like some irregular vessels. And then you see these brown dots. I would call them brown. Here, I think they're a little gray. I think it's often hard to see these different colors that we all talk about, but to me, this looks brown up here, but then this looks more gray. Hopefully you guys can kind of appreciate that. It looks a little bit hazy here, but you have all these dots around the periphery. My main differential with this lesion was just like we talked about just now, maybe a weird pigmented BCC because of the dots, like the tiny dots and the globules, an LPLK, or some unusual melanocytic lesion like a melanoma undergoing regression. So thankfully, we biopsied this, and thankfully it was just an LPLK. Kind of nice to see these two side by side. And then just another compare and contrast, the one on the left we literally just looked at. The one on the right, this is obviously a clinical lesion. So already to begin with, this lesion is really odd. It's very large. This is the shoulder. So it's like at least several centimeters or more. And, when we saw this in clinic, we weren't so sure what was going on. Patient didn't give a great history. You see this like central hypopigmentation. There's some erythema. I almost wondered, is this like a weird patch of vitiligo because it goes all the way up here? And if you look at the periphery, you kind of see the same features. Like you can see some small gray areas. There are some small dots. There's also brown pigment, of course. And there's a marker sign. So we biopsied this area, and same differential. This actually turned out to be a large neglected BCC, superficial BCC, which makes sense because, if it's anything, it would be very strange for a large LPLK. It'd be super weird for a melanocytic lesion. Like if this was a melanoma, there's no way it would have gotten this big. So this was just a BCC that the patient didn't have any idea was there and hadn't treated it. So it got really, really large. So just kind of an interesting case that we had. Just one more comparison and contrast. So you can see how sometimes it can be really challenging to distinguish some of the things that we've just talked about. So both of these lesions have these small pigment dots, and they're kind of distributed throughout the whole lesion. You do see some fine vessels here in the middle, but the lesion on the left is a basal cell carcinoma. The lesion on the right is actually just an LPLK. but you can see how similar they look. And, when I biopsied the one on the right, that was my main concern was is this just a lichenoid keratosis, or are we missing a pigmented BCC? So you can just see the similarities here. Okay, so we're gonna move to melanocytic lesions. I won't go over, I'm gonna go over just some basics here. The pigment network is really the thing that you're looking for with melanocytic things. And so if you see a reticular network, you know that you're into the melanocytic category. And the reason that you see this reticulation is because of the reedy ridges of the epidermis. That's where the pigment is. And, if you look top down, you see this kind of mesh-like network of brown lines. A negative network is the complete inverse opposite of that. So instead of brown network, you see a white network pattern. This can be seen in melanomas, but as well as Spitz nevi, dysplastic nevi, and just growing benign nevi in general. And so when I first started looking for this feature, it's important not to get confused because you'll start to see it a lot in just benign intradermal nevi, where there's normal globules, and then you just have this pale color that's kind of separating the normal globules. So this is not a negative network. This is fine. This is a benign intradermal nevus. This is kind of what a true negative network looks like. So instead of the usual pigment network, you see kind of this background of brown that's broken up by white lines. A couple more examples just so you guys can see this. The one on the left is a really nice example of a negative network. That one's pretty obvious. Both of these lesions also, clinically are you're going to know that they're concerning. But here, negative network, this was an MIS, and then there's a negative network right here in this quadrant that's being pointed out by the arrows, and this was an invasive melanoma. This one also has streaks out here, and the periphery is irregular, and then peripheral globules, which we're going to talk about now. So dots and globules. Dots are just small in size. They're 1 millimeter or less. You can see different color dots, like we've already kind of talked about with the gray dots representing regression. Black dots are higher up, so they're in the stratum corneum or the upper epidermis, and then brown dots are usually going to be around the DEJ. This lesion, I actually was worried about. I thought that the pigment network down here is a little bit thicker than up here. It's darker down here. I biopsied this and it was just a benign nevus, but going back to look at it, it has some nice examples of these normal dots that you might see. And most of these ones are in the middle of the network. So hopefully you can see that there. It's like in the whole of the network. And the reason that this is because, again, we've talked about the reedy ridges forming the actual network. And then if you have also nests in the papillary dermis, then that corresponds to a brown dot in the middle of the network. And so what you want to look for is regular dots versus irregular dots. And that's also just kind of the general theme of melanocytic lesions. And, broadly, if anything looks regular, evenly spaced, has a pattern to it, that's going to be more reassuring than something that doesn't follow a pattern. So for regular dots, you can often see them right in the middle of the whole of the network. Sometimes you can see them just in the center of a typical nevus with a reticular network. And then this is also normal too, where sometimes you see dots actually on the lines of the network. Irregular is just anything that doesn't follow one of those patterns, or if it's just not associated with any type of network. And so this here, you can see there's some dots down here at the inferior portion. There's absolutely no network. In fact, it like looks white here. And so these are irregular dots and definitely concerning. This was a lesion that had, at first glance, it maybe doesn't look too concerning. There's kind of this darker blotch here. And then you start to look and there's these small dots at the periphery. But they're not, around the whole periphery. There's just some here. These ones out here are not really, like you can't really see a pigment network there. And so this was an MIS. Globules are the same thing, just bigger in size. They're 1 millimeter or bigger. You often see this cobblestone pattern with globules. So this is like a really classic intradermal nevus. Same kind of idea. If they're regular globules, they're going to be either distributed throughout the whole lesion like this. They're going to be maybe just in the center, or they're going to be around the perimeter, but they're going to be regular. If there's anything irregular, that's going to be a red flag. And an interesting thing about peripheral globules, I think you guys all know that this generally is a sign of a nevus that's growing. And so if you see this in a younger person, it's fine. But if you see this feature in someone who's older, you're going to want to just take a second look. This study looked at patients by decade. So this is down here, it's age group by decade. So what they found was that most of the people who had nevi that showed benign nevi that showed peripheral globules were 30 years or younger. And so, the arbitrary cutoff is if anyone's older than 30, if they're maybe in their 30s to 40s, you can monitor the lesion. And then they suggest, if anyone's like 50 or older and you're seeing peripheral globules, you should probably biopsy or excise that lesion. And then this other study kind of looked at a very similar thing. And what's even more interesting is maybe take a little bit more, more of a second look, or be more cautious if someone's older than 50 and you see peripheral globules on an extremity. So here they looked at lesions that had peripheral globules and then categorized them into melanomas versus benign nevi. And you can see here, this is just by age. So the melanoma lesions were definitely seen in older patients. And so the median age was 50 versus 34 for melanoma versus nevi. And then the melanomas tended to be, there was a kind of a higher percentage on the arms and the legs, whereas with benign nevi, most of them were seen on the torso. So just kind of an interesting idea to keep in mind, like if you see something on an extremity, and especially if that person is older, you want to be more cautious and probably do a biopsy. So going back to irregular globules, here are some more examples like this. There's a little area here, there's some smaller dots there, but it's not evenly throughout the whole lesion. And plus this network also just looks atypical itself. So all of these features make this lesion worrisome. This was an atypical nevus showing multiple globules, but they're, and they are actually kind of spaced out throughout the whole lesion, but, they're just varying sizes. There's some like going out to the periphery, and then there's a network here, but then the rest of the lesion doesn't have a clear network. So this was an atypical nevus that was biopsied. This was kind of an interesting case of a woman that had this lesion on her cheek. She didn't let me biopsy it for a really long time because it was on her face and she didn't want a scar. And so you can see these globules. So, I talked to her about biopsy. She didn't want to do it. So we decided to just monitor. And you can see this is like roughly over a year. And this is also just a quick plug for, I like to take dermoscopic photos, and I'm happy to monitor lesions, especially if patients like are refusing biopsy or are not interested. So we were able to actually take this photo for comparison and go back and look, and you can see here's where the difference is. There's these new globules here on the edge. And it was actually really helpful because I was able to show the patient this and say, look, like this is new, this wasn't here before. And she finally agreed to have this lesion biopsied, and it showed focal MIS. So, there's nothing wrong, I think, with following lesions over time, as long as your patient is going to be reliable and come back. Obviously, that is something you have to keep in mind. And then taking these dermoscopic photos is really helpful. And then this was an older patient, definitely over 50, on an extremity, and had these, I wouldn't call these peripheral globules, they're not, but just kind of these globules only in one half of the lesion. So not throughout the whole lesion, and this was an MIS. There are some other features to look for. So this study by James et al. Actually looked at non-facial melanomas. So nothing on the face, but on chronically some damaged skin. And they basically came up with these 3 patterns that they termed. So patchy peripheral pigmented islands, angulated lines, which you're also going to see these with facial lesions or facial melanomas. And then tan structureless with granularity. So kind of what we've been talking about with this gray color and these gray dots. Very closely related to that, obviously you guys have all heard of the blue-white veil. I kind of I'm a lumper, so I lump things together. I think the blue-white veil is exactly the same thing as gray color, which is exactly the same thing as regression. It's all kind of very similar. This is due to heavy pigment in the dermis, and then you have a thickened epidermis right over it. So, you know, it makes sense that you're looking through this thick kind of haze, and then it makes the dark brown look kind of blue or look kind of gray or white. So you can see that here in the middle, and then also a nice example of this gray color. A couple more examples. And again, if you see gray, you're always going to want to think about a lichenoid keratosis, but here the gray is in the middle of the lesion. You know, there's kind of this white color as well. The main differential here was an LPLK versus a melanoma, and this was an MIS. And then here, going back to that couple slides before, you know, you could maybe call this that pattern that they described of tan structureless with granularity. There's some, you know, small gray dots here. It's kind of subtle, but I would say there's some granularity here. So this was actually an invasive melanoma, 0.4 millimeters. There's some small dots here that you can see. Another personal pearl that I've just found helpful, I've had a handful of patients where looking at the lesion itself, it's not actually that worrisome dermoscopically, but it has the ugly duckling sign. Like it stands out, it's much larger than all the other nevi on exam, and it's like a large isolated lesion. So this spot was probably close to a centimeter. You can see, you know, it's pretty big. Looking at it, the network looks pretty even. Like there's really nothing that stands out. It was just a really, really large nevus, and he didn't know the history, and it was an MIS. Similar thing, this very dark spot was on the back of the scalp. He had no idea it was there. Looking at it, again, it's just kind of this homogeneous brown, like nothing really worrisome. I wouldn't say that there are any concerning features. It was a little bit bigger than his other nevi, but not huge. I would say it was, you know, this is a millimeter, so maybe like 6 to 7 millimeters. And it was just a lot darker and slightly bigger than his other moles. And so this was also an MIS. And then same thing here, another MIS, where looking at it dermoscopically, there's really like not much that's worrisome. There's not a clear network here, but I mean, you still see the follicular openings are spared, and this lesion was maybe, you know, 8 millimeters or a little bit larger. And it was, again, just bigger and isolated. It just stood out. So always keep that in mind. Okay, so we're going to just talk briefly about acral sites. I have about 10 minutes left, so I think we're doing okay on time. With acral nevi, melanocytes normally live in the furrows, and that is called the crista limitans. That's where they hang out normally. So you shouldn't see them in the crista intermedia, which is where the ridges are and where the eccrine duct openings exit the skin. So this is a really typical benign pattern of an acral nevus, and you can see that you can actually see the acrosyringia. I'm trying to highlight them here, but the more you look at acral skin, you'll just be able to really easily see, like, okay, this is a ridge. So then the pigment's in the furrows. You can see actually the little acrosyringia opening here. All of these things are well, not the parallel ridge, but all of these things are variations of the exact same pattern. So it's all parallel furrow patterns. And what is interesting, and what many of you probably already know, is that the fibrillar pattern is just from pressure. It's it's exactly the same thing as a parallel furrow pattern. It's just from pressure. So here on the top, the melanin kind of comes out through the epidermis and then should go straight up. And you see that down here histologically, melanin is just in this vertical column. But with pressure on the stratum corneum from walking and from standing on your feet, it's going to smush the stratum corneum. And so that everything's going to look a little bit diagonal. So you're going to see all these wispy diagonal lines that make up a classic fibrillar pattern. When you actually correct for this and you look with the dermatoscope and kind of angle it and compensate for this direction, you see that it is just a parallel furrow pattern. So that's the same thing highlighted here, where this is a fibrillar pattern, but if you correct for kind of the misalignment, it's just a parallel furrow pattern. So keep that in mind, that it's only going to be on the pressure areas of the foot, and then you really shouldn't see it anywhere on the palms unless someone's like really doing, you know, a lot of manual work or like really using their hands where there might be a ton of pressure on the palms, but you're never going to see fibrillar pattern on the palms. This study by Miyazaki's group was kind of interesting and highlights this because they looked at these 3 different patterns, and you can see that the fibrillar pattern is in areas of pressure. So ball of the foot, kind of the lateral side of the foot, and then heel, and then the toe pads. And they really don't see this pattern in non-weight bearing areas of the foot. The normal parallel furrow pattern tends to be like kind of around the periphery of the weight bearing areas. And then the green represents, you know, non-weight bearing areas, you know, unless someone's like super flat footed, but usually, you know, here in the arch of the foot, this is actually where they saw most of the lattice-like patterns. So that's where it's kind of looks like a network. And sometimes around the periphery as well, and some of the toes. The idea is that maybe the normal skin lines there are not just normal parallel lines. They probably have, you know, kind of crossing sulci. So you just get a normal parallel furrow pattern in a lattice distribution. Now, this paper was kind of interesting because they did look at a very specific group of lesions, but they are suggesting that maybe melanomas occur in areas of pressure. And I put a couple question marks because I think still yet to be determined. What they were looking at was actually specific acral pigmented lesions that didn't have any dermoscopic patterns that were typical. So that includes the parallel furrow, but also parallel ridge pattern, which is usually, you know, seen with melanomas. These were lesions that didn't have any clues dermoscopically. And most of them were nevi, and then just a few melanomas, and then some equivocal lesions. And they kind of plotted out where on the foot and hand they were. And so on the top here, these are all the nevi. And then on the bottom is just, they included the melanoma cases and then the equivocal cases. And they're kind of suggesting that maybe the melanomas are seen more in these pressure areas, like the side of the sole and the heel. And it's kind of an interesting idea that maybe areas with more repetitive trauma are more likely to develop melanomas. It's kind of the same idea, like, you know, areas of chronic inflammation might develop SCCs. Obviously, the big caveat here is that, I mean, they have very few melanoma cases. And so I think it's an interesting idea, but more to be determined on that. The parallel ridge pattern is usually a worrisome thing. These are acral melanomas where here, again, you see the acrosyringia, so you know that this is a ridge and the pigment is throughout the whole ridge. There are some exceptions to the parallel ridge pattern. So these are all benign things that sometimes you'll see parallel ridge pattern with. So you can see hyperpigmented macules with Peutz-Jeghers, Laugier-Hunziker. You know, in certain skin types, you see numerous hyperpigmented macules on the soles. Sometimes those have parallel ridge patterns, or often they do, and they're going to be multiple lesions. So those are benign. Any sort of exogenous pigment, that makes sense. It's going to be on the surface, you know, on the top surface of the skin. Chemotherapy-induced pigmentation, and then often congenital nevi will have this parallel ridge pattern here. So this is a congenital nevus. This is just normal, like ethnic pigmentation on the soles. And this is a dermoscopic photo showing that the pigment is mostly on the ridges, but these are all fine. Subcorneal hemorrhage is also going to have the parallel ridge pattern. So that's because blood comes out of the skin in the area of least resistance. So it goes around the acrosyringia. And so it's always going to be on the ridges. Some clues that you're dealing with blood and not a pigmented lesion are that it's the color, mostly it's going to be more of a red color. You often see these satellite lesions. This is really classic for blood. And then it tends to crack on the surface. So you see all these cracks superficially. You always want to be careful because you don't want to miss some sort of underlying malignancy that is causing secondary bleeding. So, you know, even though you see blood, you want to make sure that there's not something hiding underneath. And you can always do a scratch test. So you just take a 15 blade, same as you would pare a wart down, and all of the pigment and color is going to go away. And then, you know, you can reassure the patient too and say, look, this dark spot that you were worried about is totally gone. It was just blood. Talking a little bit just about nails. This, to me, it seemed obvious hearing it, but I think should be reiterated. If you see something pigmented, but it's only in the nail plate and it doesn't, so like here, it's only in the nail bed and it doesn't go proximally, it has to be blood. It's not going to be a mole. It's not going to be a melanoma. Like, you can reassure the patient. So say it was just this like dark black spot. This is obvious because you see these little satellite dots of blood. But if you only see something that's just in the nail bed, it has to be blood. And that's because melanocytes in the nail bed don't make melanin. So any melanocytic lesion is always going to start at the proximal nail fold and grow out. So like this, you know, this does involve the proximal nail fold, but this is obviously blood because you see these little fibrillar lines. That's because capillary action pulls the blood outwards. And then you obviously see this red-brown color too. But again, you always want to make sure that it's, you know, there's not some underlying malignancy down here that's causing secondary bleeding on top. So if you're thinking that maybe there could be a melanocytic pigmented lesion in the nail matrix, the pearl here is to actually take your dermatoscope and look end on at the end of the nail, at the toenail or fingernail, because if the nail matrix is involved, then there's going to be color that's in the nail plate itself. And going back to board spotter, if you see pigment in the top or the dorsal nail plate, that comes from the proximal nail matrix, because proximal nail matrix makes the dorsal nail plate. I always remembered this with an O in proximal, O in dorsal. The distal nail matrix here makes the bottom or the ventral nail plate. So you actually can be able to, you can look at the nail and then determine actually where in the nail matrix, proximal or distal, the lesion is. So that can help you, like if you're going to biopsy the lesion. And then you also want to counsel the patient too, because if it's proximal matrix, probably there's going to be some permanent nail dystrophy if you biopsy. Okay, I just have a couple more slides. We'll run really quickly through them because I think trichoscopy is interesting, but it's like, you know, could be a whole other lecture. Androgenetic alopecia, you're going to see miniaturized hairs and sometimes this perifollicular hyperpigmentation. So I often use my dermatoscope when I'm looking at the scalp. Alopecia areata, you see black dots, you see these classic exclamation mark hairs where they're wide at the end and then they taper down as they go into the skin. And then yellow dots, sometimes you can see that's more chronic disease and it might suggest actually a worse response to treatment. FFA and LPP I've put together because often you're going to see perifollicular erythema and scale. I think these are some nice examples of what you would see with your dermatoscope. And then you obviously see loss of follicular openings that corresponds to the scarring. And you see these kind of lonely terminal hairs at the edge, which is classic for FFA. And then just something fun, you can diagnose tinea capitis with dermoscopy or trichoscopy. So clinically, you're going to see hair loss with scaling, inflammation, and maybe pustules. And you can see these little comma hairs. You can see black dots. So don't get it confused with alopecia areata, because you'll see, hopefully you should see these little corkscrew hairs, or sometimes even Morse code-like hairs where there's these little dashes. And it tends to be, it's not always a hard and fast rule, but usually trichophyton that causes corkscrew hairs and microsporum that causes Morse code-like hairs. So just kind of a little fun tidbit to end on. And I know we're out of time, but this is just kind of the pearls that we went through with the whole lecture. And thank you guys for listening.